So yes, thank you everybody for coming, and thank you, IPSEN, for inviting me for these rounds. So the idea of today's talk is to talk about what happened in ESMO this year. This happened in Berlin a couple of weeks ago. Very exciting for uro-oncology in general, specifically for urothelial cancer. Wasn't that exciting for RCC, but it was quite active as well. Um, so this is my declaration of interests. And let's move with the ESMO highlights. The main focus of this Congress was about adjuvant validation, triplet strategies, and smarter sequencing. So this is probably the most important trial that we saw in RCC in the adjuvant setting. This big phase 3 trial, the Rampart trial, which is an international phase 3 randomized control trial of adjuvant durvalumab monotherapy or combined with tremelimumab for resected primary renal cell carcinoma. This was presented by Dr. Larkins from the Royal Marsden in the UK. So basically, this is the study designed from the Rampart trial. It was a multi-arm, multi-stage platform designed. It included patients with confirmed RCCs and high or intermediate risk of relapse using the Leibovitz risk score, which is different than the risk scores they use in the other adjuvant trials. They had to have fully resected synchronous ipsilateral adenal metastasis or with a single fully resected soft tissues metastasis. And patients were randomized 3-2 to an arm A, which was active monitoring, arm B, which was durvalumab for a year, or arm C, which was durvalumab for a year, and 2 cycles of tremelimumab at day 1 and week 4. Of note, and importantly, the original sample size was supposed to be 1,700, but due to COVID and the Keynote 564 results, sampling was becoming harder and harder, so they had to modify the design. And the new target sample was 750 patients. The primary outcome was disease-free survival, and they did a pre-specified and pre-power analysis for DFS by risk of relapse at baseline. At this moment in the ESMO Congress, they only showed us the comparison between arm C, that durvalumab plus tremelimumab, and arm A, which was active monitoring. So of note, I wanted to show you this because this is new for the adjuvant setting. They included 15% of non-clear cells histologies. We don't have the results for that cohort specifically, but they're included. So that's interesting to see what happens in those patients with non-clear cell histologies. Another thing I wanted to note is that the high risk by the Leibovitz criteria was 50%. Remember that the Keynote 564 only had 8% of patients with high risk. It was a different population, to be honest. The definition of high risk in the Keynote trial was different than here, but at least here we can see that it was 50% versus 8% in that Keynote trial. It was a positive study. They showed an 8% absolute benefit in DFS at 3 years. It went from 73% with active monitoring to 81% with the combination of durvalumab plus tremelimumab. This difference was statistically significant and has a ratio of 0.65. Importantly, the positive effect was driven majorly by the high-risk subgroup. So you can see here that the DFS in the high-risk population was significantly different, going from 61 to 78%, but there was no difference in the intermediate risk population. So just to clarify how they calculated the higher, lower, or intermediate risk, they used this Leibovitz score calculation, which takes into account the pathological T-score, the regional lymph node status, the tumor size, the nuclear grade, and whether they had necrosis or not. You add all those numbers, and if you have between 3 and 5, you have intermediate risk, and if you have 6 or higher, you have high risk. Just as a comparison, the Keynote trial consider high-risk population only patients with PT4 or N1 disease. So here with a PT4 and N0 disease, you will have intermediate risk. So that's why it's different, and we cannot compare exactly the high-risk population between these two trials. The conclusion basically is that adjuvant therapy with durvalumab plus tremelimumab following RCC resection improved DFS. This is very important, mainly because we have a lot of clinical trials in this scenario with immunotherapy, and we have had mixed results. Only the Keynote 564 trial showing an increase DFS, and OS, where the InMotion, the Checkmate Part A and B failed to show a significant difference in DFS. One important difference with the Keynote trial is basically that they showed overall survival. They didn't show any OS data in the presentation at ESMO. So we're just waiting for that to see if we can compare and change our practice for sure. So many questions remain unanswered with this trial. First of all, what is the impact in overall survival? I think that's the most important question. What are the outcomes across clear cells and non-clear cells histologies? I will be very interested to see if we had any effect in non-clear cells histologies, because that's a population not included in the Keynote trial, and that could potentially benefit from these strategies. I also question whether the tremelimumab is useful or not. So I want to see what happens with the outcomes of arm B, the tremelimumab arm, and see if using tremelimumab or adding the anti-CTL4 actually uh, it's important or not. And the other question is if we can identify patients who do not require treatment. I think this is mostly answered, given the fact that the intermediate risk population did not show any improvement with the combination. But I will still want to see what happens with the KIM-1 high and low population, which was something used in the other trials and showed benefit of adjuvant immunotherapy in the KIM-1 high population. Moving on to metastatic RCC, there was an interesting trial in first line. This was an umbrella study called the Keymaker, presented by Dr. Suarez from Barcelona, in which they use different regimens based on pembrolizumab for advanced clear cell carcinoma. The study design was a multi-cohort platform, and they included patients with histologically confirmed locally advanced or metastatic clear cell RCC with no prior systemic therapies. And they randomized patients into like a concurrent reference. That's the lowest arm there. That was the combination of pembrolizumab. And they tried the 4 different triplets. The first arm using anti-LAG3 plus pembrolizumab. The second one used an anti-TIGIT plus pembro and belzutifan instead of lenvatinib. The third arm used an anti-CTL4 plus pembro plus lemba. And the last arm was a combination of belzutifan, HIF2 inhibitor, pembrolizumab, and lenvatinib. The primary endpoint was overall response rate, and secondary endpoints included duration of response, PFS, and OS. So importantly, the primary endpoint was not met, and the overall response rate was higher in the reference arm. So you can see there that the response rate for the pembrolizumab combination was 80.6%, which was surprising, knowing that the clinical trial in the phase 3 clear trial, the response rate was 71%. So surprising to see an 80 almost 81% of response rates in that arm. But you can see that none of the other arms showed similar response rate. Perhaps the belzutifan arm showed a similar, if you want, response rate with 77.5%, and the anti-CTL4 one with 71%. The only thing I would want to show here that probably is different between the arms is the arm using belzutifan, pembrolizumab had almost double the complete response rate compared to pembrolizumab. But more importantly, in these other secondary endpoints of duration of response, PFS and OS, this combination using belzutifan showed improvement in duration of response, PFS, and a trend towards improving OS, which is probably the more interesting part of this trial. The good thing is the two triplets that did best in this trial are currently under evaluation in a phase 3 trial, the LightSpark 012. This trial is ongoing. We're waiting for the results, but as you can see, this trial randomized patients to pembrolizumab or pembrolizumab plus belzutifan or quavonlimab, which is the anti-CTL4. So the conclusion of this trial is that triplets were not able to show better overall response rate than pembrolizumab, but again, it was hard to beat with an overall response rate of 81%. They have promising long-term signals with belzutifan combination, and we will await from the LightSpark 012 trial to see if this changes our practice or not. Moving on to, again, metastatic RCC, optimal second line. We have 2 trials I wanted to show here. The first one was this phase 2 multi-center trial called LENCAVO, which basically randomized patients to either lenvatinib plus everolimus or cabozantinib in patients with metastatic clear cell RCC that progressed to a PD-L1 immune checkpoint inhibitor. So this is the trial design. You can see metastatic clear cell RCC with prior PD-1 or PD-L1 immune checkpoint inhibitor and randomized patients to lenvatinib, everolimus, or cabozantinib. Primary endpoint was PFS. Secondary endpoints was overall response rate, safety, and overall survival. So first of all, I wanted to show you this because these populations were not exactly balanced, and especially I wanted to show you that the everolimus group showed fewer patients with PS0, fewer patients with IMDC favorable risk, fewer patients with only one prior line of therapies, and more patients with prior nephrectomies. So the question here is whether this was actually a worse population, because in the cabo group, they were more patients with PS0, more patients with IMDC favorable risk, more patients with only one prior line of therapy, and fewer patients with nephrectomies. And as you can see in the bottom here, the main first line treatment use was ipi-nivo. Almost 70% of patients used prior ipi-nivo. Only 15% or between 15 and 20% use pembrolizumab or a combination of IO and a TKI. But even having a worse population, we can see here that the study met its primary endpoint and the median PFS was improved with the lenva everolimus combination from 10.2 months to almost 16 months, 15.7 months, with a hazard ratio of 0.51 and a statistically significant p-value of 0.02. The difference in response rate and overall survival was not significant, but numerically important. You can see that the response rate with the lenvatinib everolimus combination was 52%, where it was 38% with cabozantinib. But importantly, the disease control rate was similar, over 90% in both of these combinations. And very few patients had progressive disease as best response. Only 3 patients in each group, around 7%. No difference in OS. But as you can imagine, toxicity was higher with the everolimus combination, showing more patients with serious adverse events, more patients with grade 3 and 4 adverse events, and more patients having treatment discontinuation, 20% versus almost 11%. So the conclusion is that among patients that had progressed on prior PD-L1 checkpoint inhibitors, lenvatinib plus everolimus significantly prolonged PFS over cabozantinib. But again, a lot of considerations in this trial. First of all, and I think that this is the most important part, is that this is a positive phase 2 trial that demonstrate efficacy of these regimens in the post-IO setting. You know that the Meteor trial using cabozantinib didn't have patients with prior IOs, nor the trial that give approval for the Evo combination. Main question is whether this will impact overall survival. And other question is if we can extrapolate this to non-clear cells and no prior IO exposure population. And my question that I ask myself is whether PFS and response rate is enough to change my practice. And I would say that mostly no, but I will consider using everolimus if I have the chance, if it's approved here in Canada at some point, only for patients in whom the priority is response and for whom the higher toxicity rate is acceptable. I would say that there are not most of the patients. I would say that's a few proportion of the patients that get to second line, but it will be nice to have this combination to at least have this discussion with patients. The trial I wanted to show you in the second line setting was this Chinese trial that that's a phase 3 trial using fruquintinib. This is a TKI plus sintilimab. This is an anti-PD-1 versus axitinib or everolimus monotherapy as second line treatment in patients with locally advanced or metastatic RCC. So on the top left, you have the study design. Again, patients had to have clear cell histology, and they were excluded if they had used immune checkpoint inhibitors in the past. So patients were randomized to the combination of an anti-PD-1 and a VEGF targeted therapy, the fruquintinib plus sintilimab, or what is apparently the standard of care in China, which is axitinib or everolimus. Of note, I didn't put the baseline characteristics here, but almost all patients use axitinib in this trial. I think only 5% of the patients use everolimus. So this was basically a comparison between the combination and axitinib. The primary endpoint was PFS, and as you can see in the top right square, this was a striking improvement in the median PFS from 6 months with axitinib everolimus to 22 months with the combination. And if you see in the bottom, a significant improvement in overall response rates as well, with a 60.5% in the combination versus a 24% with the axi everolimus. So this is very encouraging. These combinations, I don't think will be available here in Canada, but it's nice to see that in patients that use only a TKI in first line, using a combination of anti-PD-1 plus a TKI significantly prolong PFS and improve overall survival. Moving on, coming back again to localized RCC, there was a nice small trial of neoadjuvant treatments in RCC, which is a novel strategy, not very investigated so far. So it was interesting to see some prospective data in this thing. So they presented this NATIO trial, a phase 2 trial, that randomized patients to 3 different immunotherapy combinations for patients with histologically confirmed resectable clear cell carcinomas with no history of distant metastasis and no prior immunotherapies or immunosuppressive medications. And they were randomized into 2 cycles of nivolumab alone, 2 cycles of ipi-nivo, or 2 cycles of relatlimab and anti-LAG3 and nivolumab. Only 2 cycles, nephrectomy, 7 to 8 weeks after starting or after randomization. And the primary endpoint was pathological response rate, which in this trial, that was defined as a response higher than 50%. So the trial was positive, and they were able to meet the primary endpoint of at least 2 pathological responses. For the arm B and arm C, ipi-nivo had 2 near pathological complete responses, and the relatlimab plus nivolumab arm show 1 partial response and 1 pathological complete response. Importantly, what they show, and I think it's probably the most important part, is the curve in the right, showing that those patients, again, there were just 5 patients, but those 5 patients that had a response higher than 50%, none had recurred after 18 months. So the relapse-free survival at 18 months was 100% versus 83%. So this is preliminary data, but it's encouraging to see what will happen with these patients eventually with longer follow-up. A couple of things about biomarkers. So they show this very encouraging molecule, the KIM1 molecule, that kidney injury molecule 1. So we've seen some data in the past in the adjuvant setting showing that patients with higher KIM1 after an nephrectomy had higher risk of relapse, and probably those patients benefit the most with adjuvant immune checkpoint inhibitors. There was some evidence in the nivolumab trial in second line showing that higher KIM1 give poor prognosis and patients live less with higher KIM1. And here from the Cosmic 313 trial, if you remember, this trial was the trial that randomized patients in the first line setting with the intermediate or poor risk disease to the combination of nivo-ipi or nivo-ipi plus cabozantinib. This was a positive trial in PFS, but failed to show any improvement in overall survival. So what they show here, and they divided patients according to the KIM1 levels at baseline, and they divided in 4 quartiles, and you can see in both arms in nivo plus ipi or cabo plus nivo plus ipi that patients with the highest quartiles of KIM1 had poor overall survival, and patients with the lowest quartile had better outcomes. So something to keep in mind. Another one that I want to show you was this OPTIC trial, which is a phase 2 trial that tried to show the efficacy of cabo plus nivolumab in cluster 1 and 2 for metastatic clear cell carcinomas. So just to refresh our memories, these clusters come from this trial, the Emotion 151, that did RNA sequencing, and they found 7 different clusters. And what they showed is that cluster 1 and 2, these are the 2 first ones, they're very angiogenic clusters. And you can see here in the PFS, this is the green square. Sunitinib did very well in these 2 clusters, whereas cluster 4 and 5 are the most IO clusters. And you can see that sunitinib, the box is white because they did very poorly with sunitinib, and they respond much better with IO combinations. So based on these results, they did this trial in which they allocate patients with metastatic clear cell carcinomas with available tissue for RNA sequencing and cluster prediction. And they allocated patients with cluster 1 and 2 to nivo cabozantinib, cluster 4 and 5 to ipi-nivo. This arm is still open to accrual, so we don't have the results of this arm. And cluster 3, 6, 7 were excluded from the trial. They show us here the cluster 1 and 2 and the results from nivo cabo. The primary endpoint was objective response rate. By their perspective, positive trial will be if the response rate was higher than 75%. This was a positive trial because the objective response rate was 76%, but importantly, no patients progressed with this treatment, and 100% show some side of tumor burden reduction. As you can see in the waterfall plot in the right, all patients had at least had a minimal tumor shrinkage. So very encouraging, not practice changes at the moment, but very encouraging. Oh, and I'm just realizing that I'm almost done with a lot of time to spare. But moving to real world evidence from the IMDC. So this time there wasn't much activity from the IMDC in ESMO. This is a trial, a poster that we presented, in which we tried to show the durability of complete responses in different treatments subgroups. So basically, we just selected patients with complete responses in our database. We can see that the complete response rate for IO-IO combinations was 6.25%. For IOBE was almost 4%, 3.9%. And with VEGF, only 1.5% of the patient had complete responses. So in the middle, you can see the overall survival by complete responses. So first of all, overall survival for these patients is very, very good. At 4 years, 93% of patients treated with IO-IO were still alive, where 100% of patients treated with IOBE were still alive, and 94% of patients treated with VEGF targeted therapy. I think this is very important, specifically because we have this concept that patient achieving response with ipi-nivo has the best outcomes long term, and we always. I think that the world is suspicious about whether IOBE patients had these long-lasting effects. And what we can see here is actually that they do. If you achieve a complete response with IOBE, the chances of being alive and progression-free are quite good. So this is the TTNT, which is basically what we use as a PFS in our database because we don't have the date of progression, but we have the date where they start a second treatment. And you can see it was not reached with neither of these three arms. But if we select patients that did receive a second line, there was a small number, just 5 patients with the IOB group, 19 patients with BGF, and 11 patients with IO-IO combinations. We can see that the median time to a second life in those patients that will need a second life eventually, it was extremely long. So 30 months for the IO-IO, 46 months for the IOBE, and 23 months for the BGF. Another important thing that I wanted to note is that from the IO-IO cohort, 11 patients started second line. 7 of these patients had an IO rechallenge. And in the IOBE cohort, 5 patients started second line, and 1 of those patients had an IO rechallenge. So in total, 8 patients were rechallenged with IO. And of note, we had 2 new complete responses, 4 partial responses, and 2 stable diseases. So none of the patients rechallenged with IO in this subgroup of patients with complete responses had progressive disease. So the conclusion was achieving a complete response confer an excellent prognosis, but that not equal cure. So you can still have relapses. Relapses can occur in both patients treated with ipi-nivo and IOBE, and the retreatment with IO may be effective in the patient that progresses. So, yeah, sorry for being so fast. I think that's all. Thank you, everybody, for being here. I hope you enjoyed it and that you had a nice lunch. And yeah, open for questions now.
Any questions? The ones in the Zoom or people in the auditorium? maybe I'll start first. I have several questions, Martin.
Sure.
First of all, congrats for the poster presentation at the ESMO GU. Regarding your abstract, did you also include radiation therapy for the TTNT calculation,
No, no, we
or
don't have
was
that
it only the
information.
systemic?
Only
Okay,
systemics.
only systemic therapy. Very interesting. Uh, one more question. Regarding the ASMO GU highlights. From the first Rampart clinical trial, as you know, there has been mixed results for adjuvant trials so far. So here in Sunnybrook, I guess we don't really offer that much of adjuvant immunotherapy when it comes to those settings, because of the results and also lack of evidence when it comes to non-clear cell settings. I was just curious about the practice in Calgary. And also, do you anticipate any changes depending on the upcoming results of that Rampart clinical trial?
So yes, I know that you don't like to use immunotherapy as an adjuvant setting. Um, we do use it here in Calgary and fairly frequently, to be honest. Yeah, we think that even though we have these mixed results in the ICI trials, we cannot deny an overall survival benefit. And it was statistically significant and patients live longer with adjuvant immunotherapy. I think the question is to who? And and especially from the keynote trial, we know that the benefit comes from the intermediate risk population. In this trial, the rampart is for the high risk population. Um, our concern always is with the high risk population and whether we're under treating them with pembro alone. So having this option with a combination of anti-CTL4 and anti-PD-1, I think will change that for the high risk population eventually if they show overall survival benefit. If not, I don't think will change anything. But yes, here in Calgary for intermediate risk, we tend to recommend and use pembrolizumab as an adjuvant treatment. We're more conservative in the high risk population or in the M1 NED population, in which in those population we did not see any OS survival benefit. So we try not to use it unless the patient is really pro and wants to do it. Um, but for the intermediate group population, yeah, we offer it and we use it fairly frequently.
There was a message. Can you tell us more about the Cabo-C clinical trials since you're taking a major part of it?
So yes, none of the Cabo 6 trials were presented at ESMO, but there was one in ESMO GU and one in ASCO GU and one in ASCO. So the one in at ASCO GU, we basically tried to we tried to show the efficacy of cabozantinib second line uh, from different first lines. So the question here, at least in Calgary, I don't know how it's in Toronto, but we cannot use cabozantinib after ipi/nivo because of the Metro trial only have 5% of patients with prior IO. So we try to show that cabozantinib is effective irrespective of the prior line. And we actually saw that even if you have BGF combination with IOB or IO, cabozantinib performs similarly with good response rates and good long-term outcomes. Um, and the other thing that we did in ASCO was the Cabo 6.5, in which we use artificial intelligence and we gave there our database and see if the artificial intelligence was able to predict or detect groups of patients that respond differently to different treatments. And we did find very interesting things. Basically, what we saw is that BGF underperforms irrespective of other variables. But for example, for the IO-IO combination, we know that patients that had a prior nephrectomy and has only lung metastasis, response rate can improve significantly. And response with IO-IO in those patients were around 60 or 65%. So much higher than the clinical trial, which was around 40, 41%. So if we select these patients, we know the response rates are better. So no sort of prior nephrectomy and only lung mets, IO ipi/nivo works very, very well. For all the other groups, IOBE usually perform better, especially in patients that had prior nephrectomies and patients that were younger than 75 years old. In those populations, in those groups, the response rate to IOB was around 65 to 70%.
Very interesting. When you were talking about the AI-assisted analysis, is it only the clinical pathologic factors that is included in the analysis, or do you also have
No,
like
no,
slides and like
m-
everything? in-
mostly clinical factors. So yes, was things that were important were the prior nephrectomies, the number of metastases and where the metastases were, um, age and gender were the most important things that they find that was significant.
So, let me ask, if uh, any questions from the auditorium or the Zoom? Uh, Please leave a message, or maybe I will ask another question while
Go ahead.
people get prepared. Yeah, I was wondering how you select first line in Calgary, for metastatic renal cell settings.
Yeah, so first of all, we take into account IMDC risk for sure. So for patients with favorable risk, we use IO TKI combinations. From there, TKI combinations, depending on whether we need response or not. So patients that are very symptomatic or high burden of disease, and they are fit, we try to favor pembrolizumab combinations. We know response rates are better, time to response are shorter. So in those patients, we try to do pembrolizumab. If the metastatic burden is not that high, we favor pembroaxi. And nivo cabo we use mainly in patients that has only bone disease. That's been our preference. From the
Mhm.
intermediate and poor risk, I will say that selection of IOTK combination is the same. It's just that we have the option of ipi-nivo, and we tend to use ipi-nivo in patients that have sarcomatoid differentiations, patients with lung metastasis or mainly lung metastasis, and in which response rate is not that important. So basically, that's our way of thoughts on the trainers.
I'll say very similar here in Sunnybrook. Well, my last question, is there a limitation for a patient who was priorly exposed to adjuvant pembrolizumab?
So yes, here in Calgary, we have this 6 month rule. So if you stop Pembro and you relapse before 6 months of stopping Pembro, we cannot use an IO combination. So we have to move to a second line treatment. We had a couple of those patients, actually two patients, and yeah, their outcomes weren't good. So we started them on sunitinib. That's our only option after an IO only treatment. Both patients died like really fast. So yes, that's the concern about using adjuvant pembro for sure. If they relapse after 6 months, we are allowed to use a new treatment, a new IO combination treatment. And we only had one of those patients, and they respond very well to the combination.
I see. So there is a question from Dr. Amanagar. He asked, how well the tremelimumab and the durvalumab combination was tolerated by the patient, for the first ESMO highlight.
Yeah, sure. So there was nothing surprising about the toxicities, things that we're used to. I didn't see anything that was different because of the tremelimumab part for sure. Um, yeah, all IO toxicities as we know them, like hypothyroidism, some things like that. But nothing significant. That's why I didn't put that slide there. Um, but yes, it will be interesting to see if when they show us the arm of the durvalumab alone, whether there is a difference in toxicities in that setting. But yeah, for now, nothing that wasn't expected for sure.
Any questions from the auditorium? So there's one more question from Dr. Amanagar. What is the next big thing in RCC, from your perspective?
Well, that's the big question, to be honest. So there, there was nothing exciting in the last, I don't know, 3 to 4 years, to be honest, other than adjuvant immunotherapy. I think the most encouraging thing that we have nowadays is the belzutifan and try to target the HIF-2 alpha. We saw in this Keymaker trial that adding belzutifan to the pembrolizumab can give us long-term benefits in PFS and OS. But I will say that probably that's a big thing that's coming, the LITESPARK-012. It's not as exciting as urothelial, where we see all these ADCs and combinations that are new strategies. Nothing like that is happening in RCC at the moment. So yeah, we're waiting for that new thing that change situations. I think that perhaps CAR T cells or something like that could be an option in the future. Nothing that I know it's going on currently in a phase 3 trial. That's very.
There was one more question from Dr. Amanaga. Was there any trials with bispecific T-cell engagers in metastatic renal cell carcinoma?
No that I know of. Probably there may be some trials open, not here in Calgary, and not that I am aware of. But yes, that's interesting. Yeah, I can see that happen in the future.
Mhm. Yeah, from what did I know of? I don't remember any bite trials from this asthma GU.
No, nothing in the ESMO for sure. Nothing ASCO or
Mhm.
ASCO-U. No, nothing in the last couple of years. But again, they may be something open in the US. I don't know, to be honest.
Might be. Yeah. I guess another interesting abstract that was presented was I remember one abstract analyzing the pathology data's AI assisted and they kind of tried to find out some like AI assisted evidence for those who actually shows good response to IOs. So I guess that might be a game changer in the future. Uh, we'll have to follow the upcoming clinical trials.
Yes. Again, I don't think our practice will change with anything we saw in ESMO this year.
Mhm,
Just we are opening new doors and see if eventually we can change our practice, but nothing big. This.
mhm. Any other questions from the Zoom or on site? I guess that's all. Isaac, shall I wrap up the meeting?